And before we get started, I just want to provide a quick reminder. If you can, do know that these calls are recorded. And if available, please turn on your cameras. We would love to see as many faces as possible. So please, if you have a camera, webcam, a camera on your laptop, your cellular device, whatever you're using to join us today, please turn on your cameras. And again, if you all could, please put your name and organization into the chat box as we prepare to get started. Okay, it's 12:30. I'm gonna request again that everyone would please turn on their cameras. If available, if possible, please turn on your cameras. And thank you for joining the HPV Cancer-Free Texas Project ECHO. This clinic is for medical providers. So our target audience today are providers. So doctors, nurses, clinicians, anyone who works within a health system, in a clinical setting. We hope that you are in the right place, and we're excited to have you guys here with us today. This ECHO is a 4-session project. So today is our very first session. We will have 3 more occurring bi-weekly from 12:30 to 1:30 p.m. Central Standard Time. And I wanted to just introduce myself quickly. My name is Trelisa Hall. I am the program manager of the HPV Cancer-Free Texas Project ECHO. We have staff, and I want to give them a moment to introduce themselves. Our staff consists of Rachel Coughlin, Dr. Jason Turk, Anna Hassan, and Shaylin Foley. And I'm going to give those who are here an opportunity to introduce themselves. We can start with Anna.
Awesome. Hi, everybody. Anna Hassan. I'm calling in from New Orleans, Louisiana. I am the Director of Clinical Interventions on our national implementation team. I'm very happy to be here. My area really focuses in on quality improvement with different health partners, anywhere from private practice, community centers, up through health plans. Thank you.
Thanks, Anna. Dr. Turk?
Hi, I'm Dr. Jason Turk. I'm a pediatrician practicing with Cook Children's, not in Dallas as it says on the slide, but rather in Keller, which is closer to Fort Worth in Dallas. So we'll get that changed in the next iteration, right, Julissa?
Absolutely.
And I'm a general pediatrician and practicing busy practice in suburban Fort Worth, Texas, and very, very pleased to be here with you today.
Thank you, Dr. Turk. Rachel?
Hi, everyone. My name is Rachel Coughlin. I'm with the American Cancer Society, and I'm the Senior Program Manager for a private funded project called Mission HPV Cancer-Free Texas. I'm located in Austin, and I help facilitate a variety of components of this project within large health systems, federally qualified health centers, the statewide coalition, and assisting Teresa with Project ECHO. So thank you all for being here.
Thank you, Rachel. And last but not least, our guest presenter for today, Dr. Oquendo, if you could introduce yourself.
Hi, I'm Marcelo Oquendo. I'm a pediatrician. I do practice in Dallas. I also practice in Frisco, Texas, which is a little bit north of Dallas. And I have been in private practice for the last 5 years. And I also do clinical research, and I do clinical research for vaccines. And yeah, I'm happy and I'm excited that they invited me to be your speaker for today.
Thank you. Thank you all for joining. And again, I want to thank each of you for joining the ECHO today. We're really excited to start this ECHO clinic, and we're excited to learn and grow together. So I don't want to give too much time. I want to make sure that everyone received the pre-survey. You all should have received the pre-survey. I hope that you had no problem completing the pre-survey and getting that done prior to today's session. We are going to move forward. These sessions are accredited by Med Learning Group, and that is who you will be receiving your certificates from. I do have everyone's name and email, so as long as we have your attendance today, you will be receiving a direct certificate from Med Learning Group. You will receive 1 hour for each session. So after today, you will receive 1 hour of CME, CNE for today's session. Okay, so I'm going to stop sharing my screen and allow for you to take over, Dr. Oquendo, at this point. You're muted.
Unmute. Can you hear me? Can you see me? And can you see the slides?
Yes, we can hear you, see you, and we can see the slides.
All right, perfect. So let's start with the slide deck is really about a 20,000 feet overview of why we're doing this. What is HPV? What is the vaccine? Why do we use it? Why do we need it? And is it worth it? Okay, so I'm going to go. I know a lot of you are very familiarized with this, with all the topic, but there's some very specific key points that it's important to drill in, because these are the key points in the discussions that we're going to have with our parents. And sometimes if we don't have the data available, just knowing the data is going to help us be better at giving that spiel or that speech, which we're going to be focusing the rest of the sessions on. Now, what is the project? The ECHO project is going to be HPV, vaccinate adolescents against cancer. Obviously, because we understand that HPV is causing a lot of, causes multiple different cancers, and by vaccinating, we can prevent cancers not only in adolescents, but also later in life in adults. So there's a slide here when I received the deck that said, why do you want to make a point of talking about HPV? Why are you passionate about the subject? And my story, and I told Trilisha when I first met her, is that I grew up around HPV. My mother, who's a pediatric infectious disease specialist back in Venezuela when I was growing up, she was participating in all the initial studies of the vaccine when it first got developed, and it was being implemented in studies across the world, kind of very similar to what we do with COVID vaccines now. Because she was participating in these trials, she was also a speaker, and she did many conferences, and I had a lot of this material at home. A lot of the conversations that we were having at the dinner table when I was a teenager was around HPV. Of course, the HPV vaccine wasn't even available for general public, much less for boys back then. But when I started med school, that was one of the subjects that I was able to present a lot of because I had a lot of the slides and the inside data of HPV vaccine. So that's one of the reasons why I'm passionate about it. So let's talk about a little bit about the science. What is HPV? We all kind of understand HPV is human papillomavirus. It's a family of viruses that has way over 150 different variants and types of this HPV. We are all familiarized with the ones that come in the Gardasil vaccines or in the vaccinations, because it was like the first 9 and 16. There's a lot of them that can cause many different types of infection, but we focus really on the ones that are more linked and associated with cancer. So it is a very common virus, and most people will be in contact with this virus or different serotypes of this virus across their life. We have a vaccine that prevents the infection and also the infection of the progression of the infection. So the changes the cytocellular changes that are caused by the disease, that is really what we're trying to prevent with the vaccination. So as we know, HPV can cause, or the ones that we're trying to deal with, can cause genital warts, and the genital warts can be unseemly, but also the changes that are not seen, the ones that are at cellular level that can progress and are very associated with the different types of cancers, as we're going to see. So the vaccines are among the, I switched the slide without wanting to. I was gonna move something over here. So the vaccines are among the few medical interventions capable of achieving almost complete elimination of this disease. It is not often that we have the opportunity to prevent cancer. Actually, I always tell the parents there's only 2 vaccines that can prevent cancer. One is the HPV vaccine, and the other one is the Hep B vaccine that we give at birth, because it can help prevent liver cancer later in life, especially if you get infected with it early on as a baby. So we have the opportunity to treat cancers with vaccination. So for me, it's a no-brainer, and I tell that to the parents. And we had a vaccine that treated breast cancer, and you say, look, get this vaccine at 9 and your chances of not getting breast cancer goes down by 88%. Would you do it? A lot of people would say yes, without a doubt. But HPV has a different connotation, which we're going to talk about. And that's, I think, is one of the reasons why there's some hesitation. And a lot of hesitation comes from the providers, from the physicians and the nurse practitioners and PAs that are talking to these parents about recommending this vaccine. So HPV vaccine is one of the only vaccines that we have to prevent cancers. As I said, it works extremely well. Studies continue to show that it's safe, it is long-lasting, and it is effective in preventing infections that can lead up to 6 different types of cancer. And we often think of HPV as causing cervical cancer, but it also causes many other types of cancer. So we need to vaccinate more kids, because it helps prevent more cancers, more deaths of cancers, more complications from those cancers. And even if it's not death, the cost associated and the burden of the disease is reasonable to vaccinate more kids. And we can be successful. And there's lots of campaigns that have shown real, movable, actionable success based on vaccination campaigns. So about cancer, of course, we understand that out of the types of cancers that we can get out of HPV, cervical cancer, vulvar cancer, vaginal, anal, penile cancer, and throat cancers, most of them we can't really test for. So we screen with the pap smears for the cervical cancer, but we don't really test for any of the other ones. And even in boys who can have, and I get that question all the time, especially from mothers of boys, is can we test them for HPV? And the reasonable answer is no, we can't. So we don't really screen for any of that. We only screen for cervical cancer, but it's associated with a lot of other different kinds of cancer. That's one of the also important reasons why vaccination helps prevent these things. So we need to focus on prevention and not just on screening and treating after the fact, if we can make an impact. Now, vaccination can prevent 92% of these. So this data shows the average number of new cases probably caused by HPV. Out of these 6 types of cancers, nearly 35,000 cancers per year in the US, and vaccinations can prevent about 92% of these. This is an incredible number. It baffles me that more people don't understand that this number, and they ask questions or hesitate about getting this vaccine when you can tell them 92% of these cancers can be prevented. So these cancers are attributable to HPV in the United States. And this data from 2011 to 2015, and attributable cancer is a cancer that probably caused by HPV. So HPV causes near all cervical cancers and many cancers of vagina, vulva, penis, anus, including rectal squamous cell cancer and oropharynx. And oropharynx has actually, I don't know if you see, and I think I don't have my pointer. I don't know if you can see my pointer, but the oropharynx cancer has surpassed 11,000, surpassed the cervical cancer as cancers probably caused by HPV. So everyone focuses on HPV vaccination for women and for girls, but honestly, I mean, men have oropharynx too. And we, by vaccinating men and women, we not only help prevent the spread in girls and females and women, but we help prevent a lot of cancers in men as well. So not just the penile cancer, which yes, the number is not as impressive as 2,800 or 2,200 or 4,200, but it is still significant. And especially for boys, if you tell the parents, look, you could get penis cancer, and that could mean the amputation of the member, then a lot of them will think twice and say, well, maybe I should get it. Okay, but I think oropharynx cancer is really something that we need to focus on moving forward in the spiel that we give about vaccinating against HPV. So more than 1 million women are affected each year. So actually nearly 2 million women have abnormal pap smears or HPV test, positive HPV test. So out of these, more than 1 million new cases of low-grade cervical dysplasia, which we understand at this point are precancerous. So, and then the 200,000 new cases of high-grade cervical dysplasia, no precancer, but one is very likely to lead to the other. And these are not yet cancer, but it doesn't mean it doesn't carry a significant amount of importance, because of what I'm about to show you is that all the potential stress of knowing you have a diagnosis, the added follow-ups that you have to do as a physician and as a patient, the time it takes from having to take off of work, going into the doctor, stigma that is associated with it, the family or the spousal conflict that can arise from having this diagnosis and having to go in and going to see the physician. So because of the hundreds of thousands of women that are diagnosed with a high-grade cervical dysplasia, these women require additional treatment to prevent cancer. And that's what I wanted to talk about. And I mentioned this to a lot of my female patients, is just because you have a positive screen with a SIN3, you have the pre-cancer. Most of the time, the leap or the loop or the conization, where we take a chunk out of the cervix to not only completely biopsy, but also as a treatment. And it's quite effective. The only problem is that it can lead to cervical dysfunction. It can lead to obstetric mortality, preterm delivery, low birth weight. Of course, it has the cause. It is not a pleasant, and I had to do these when I was in med school. These are not a pleasant procedure by any stretch of the imagination. So if we can prevent this for our patients in the future, it is, again, a no-brainer. It's hard for me to understand why, given this information, people would not jump to get in line to get it. So vaccination helps prevent the precancers in a large amount. So if we vaccinate our teens early or preteens early, the chances of them having to ever even have to go through this drops significantly. And we're talking about over 90%. So not only the cost, but also the complications of delivery at the time of pregnancy and delivery. Now, this is a kind of representation of all these cervical cancers, and that's 13,000 new cases of cervical cancer at the tip of the pyramid. And I guess I imagine that you guys are not seeing my pointer, so because I'm pointing on the screen. So if in case you don't see it, I'll try to be more clear of what I'm talking about. But in the pyramid,
we can see it, Dr. Oquendo.
Okay. Good. So in the pyramid, of course, we see these 4,000 cervical cancer deaths and 13 new cases of cervical cancer, but also as it goes down, we're talking about less and less severe, I guess, illness, but 1 million new cases of genital warts. I mean, that it can cause severe social, emotional, psychological, and not just medical impairment and stress on patients. So these all have a significant cost. So 2.23 million cases, about $7 billion in cost to be able to treat, diagnose, manage all of these things. So without vaccination, the annual burden of genital HPV-related disease in females alone. So if we extrapolate that information to prior pyramids with the projection of the vaccine effectiveness, we have an 88% reduction in cervical cancers. That is incredible. More than 50% reduction in the SIN2s and 3s. So the intranasal, I draw a blank. The neoplasias in grade 2 and grade 3 requiring a LEEP, and more than 75% of these can be reduced if vaccinations under the age of 14. And we'll talk about what the importance is and what the data is on early vaccination instead of late vaccination over 92% reduction in genital warts and 35% reduction in the neoplasias that we're going to find in our pap smears. Now, 13,000 cases annually of oropharyngeal cancer. I can't stress this enough because when I was in med school, we talked about oropharyngeal cancer as consequence of smoking and alcohol in the vast majority of cases. Men over the age of 50 with either smoking, GERD, reflux, those were the reasons why people talked about oropharyngeal cancer. I think everyone has heard by now of the case of Michael J. Fox in Return of the Future, how he had cancer and related to HPV, and he had to undergo procedure. This is, I think he was one of the ones that kind of brought into light that this is happening now more and more and more because of HPV. So the vast majority would say because of HPV. So oropharyngeal cancer has surpassed cervical cancer as the most common HPV-related cancer. As I showed you in the previous slide with the pie charts, HPV-related cancers have more than doubled in the past 3 decades, rise in incidence in changing patient demographics due to HPV. Okay, we can't screen for HPV in the throat, unfortunately, and a lot of times we realize that when it's kind of already in late stages, which worsens the burden of the disease, and we can prevent these by early vaccination, both in boys and girls. Now, this kind of exemplifies who are these people who are getting oropharyngeal cancer, and then obviously it's mostly men. White men in the age of 50s are the ones that are typically more associated with these type of cancers, men over 65 years of age, and then women are kind of down here. But this is one of the reasons that one of the points of data that we can use to tell our parents, look, if you have a boy, the people who get most of the oropharyngeal cancers, and it's on the rise, and we're getting more and more of these, are going to be in your boy when he's 50. You're not going to be around maybe to realize that he's going through this over a decision that you're making right now when he's 13, 12, 11, or 9. This is going to be something that he's going to have to deal with it in 50 years, and you might not be around to do it, but it was based on a decision today. So now that we've gone over a couple of the basics, we're going to talk about the HPV vaccination and is it effective, okay? Kind of briefly, and we're going to go speed through these. In cervical, vulval, vaginal, anal, high-grade cervical dysplasia, genital warts, it is obviously effective. HPV vaccination will prevent about 90% of these 60 cancers. Okay, so 90% of cancers will be prevented over one series of vaccines, 2 doses, hopefully, if you're starting early. And even data, which I think is not part of this conversation, but I have seen data very recently as last year showing that even a single dose helps reduce the prevalence of cancers later in life by an enormous amount. So especially the sooner you start it. So right now our recommendation is still 2, but when I started it was 3 for everyone. And we've realized that the sooner you start, the less likely and the less doses that you require. So that's why on-time vaccination is key to preventing these cancers. So dramatic decrease in high-grade cervical lesions among US women. And if you notice this is kind of before and after the vaccination. So estimated number of high-grade cervical lesion diagnosed amongst women from 2008, that's the dark blue bars, versus 2016, that's the light blue bars. Note that this population impact, especially right here, and 18 to 20 and 20 to 24, this is pretty impressive. So it is after the introduction of vaccination. So I think this is the more important one. This one is very impressive, but I think this is very important because most of the cervical cancers in women kind of happen in kind of this age group. Sometimes even earlier than that. I had recently a teenager, 18, who had gone hysterectomy because of an advanced cervical cancer that was progressing really quickly. So, I mean, having a less than 20-year-old having to deal with this because she was not vaccinated is just, it's painful. Decrease in cervical cancer in young women. again, more evidence to show how effective this is, corresponds to decrease in cancer of 29%. And this publication of cervical cancer incidence in young women and females after human papilloma vaccines introduction. It is effective. 0 cases of HPV. This is a Finland study versus 10 cases of all HPV-associated cancer in non-treated, so non-vaccinated. This corresponds to a vaccine effectiveness of 100%. Of course, small group, but still, it's 100%. Small group, 65,000 people versus 124,000 people, but this is 0. So if you had to translate to almost any other vaccine that we have in market for anyone, this is an enormous amount. Cumulative incidence of cervical cancer, yes, we understand. I'm going to kind of jump through safety, okay? Because I think it's very clear the vaccine works. Almost 100%, 90% of cancers reduced, right? So is it safe? Because I've had families tell me, I read on Facebook or on Instagram, on Twitter, on TikTok, I've read online that it has side effects. And not only the kind of the more emotional side effect of this allows my child to have sex, but more of there's significant discussion about the safety of this vaccine, and they pull out all this data that is floating around the internet. But there's plenty of studies that have shown no increased risk of anaphylaxis, GBS, stroke, blood clots, venous thromboembolic events, autoimmune disorders, with a lot of people kind of worry about autoimmune disorders, ovarian insufficiency, rheumatologic conditions. So all the studies that we have, or the vast majority of the studies that we've had that looked at side effects from the vaccination, find other than the regular side effects of vaccines, we don't really see anything else. So if you want to see more, 109 studies, 2.5 million people, 6 countries have shown no serious side effects. I can't make it any clearer than this, than what's typically found in all vaccines: allergic reactions, fainting, etc. So HPV vaccination. Why are we recommending it? So we recommend it to boys and girls, 9 to 12, on time vaccination, and late is after 13. So a lot of people think that late is, well, when they're 16 and up or 15 and up, that's what we call late. But no, actually, first opportunity 9 to 10, that's where I vaccinate most of my patients. 9 to 10. On time is between 11 and 12, critical 13 and 14, and then late is really after 15. We're already kind of late, and there's good data to show why this matters. So individuals aged 22 to 26 who were not previously vaccinated should be informed that vaccination at older ages is less effective in lowering cancer risk. We want to make sure that the 2 doses, especially before the critical time, if we're late, the recommendation is still at the 3 doses. And the first dose is going to be administered, and then 2 months later, then 6 months later. But if we get them on time, they only need 2 doses, and it can be 6 months apart. But more of the times than not, I do at the time I first see them, and then the next will visit. So either 9 and 10, and then at 11, they get their 2 shots for school, and then they're done. So that's the way that I usually do it. Most of the kids do get their vaccines on time. This is when they're getting their Tdap and their meningitis, but then we're not really taking the advantage of having them in the office to do the vaccinations. We're not using it to vaccinate against HPV. More and more we are, but it's still, there's a huge gap between the kids that were fully vaccinated against Tdap and meningitis and the ones that we're actually doing the meningitis, that we're doing the HPV vaccine concomitantly with the other ones. So 71.5% initiated the series in the data of the 2019, and 54% of them completed the series, which is still better than nothing. Texas, unfortunately, is not in a great position for HPV vaccination. We need to do better. We are trying to do better. But we can see that there is a big demographic disparity in regional areas for HPV vaccination. And I think Texas is as low on a lot of vaccines, not only HPV, but a lot of vaccines, and also access to healthcare, and also children who are unvaccinated and uninsured. But we still need to do better. And this is where I'm here trying to make sure we all do better. HPV vaccination is finally the new normal. 72% of US adolescents started HPV vaccine series, 54 of them fully are fully vaccinated, as I said previously. So if you tell the parents, look, the vast majority of kids nowadays get their HPV, this is not a one-off, this is not whoever wants to get it, it's really, this is what most kids are getting. A lot of times that is just enough to convince the parents to do it. So in Australia and maybe European countries had really high HPV vaccination rates from the start, and it is time for the US to catch up. And the good news is that although it took a while, the majority of US adolescents are now getting their HPV vaccine. So why it's better on time? So this is a study that showed that if you start it early, the effectiveness against the high-grade neoplasias are going to be 86% versus 51 if we start after 17, or if we do over 18, it's only 15%. And what I usually say is, look, you want to use your seatbelt before you have an accident and not after you have an accident. And that's really all it's about. We want to prevent these kids before they are exposed. And most of the time by 17, a lot of them have been exposed. So it's a seatbelt before and not after. What else? Less exposure, more chances to vaccinate, fewer doses. That's why we need to do it on time. The sooner we start, the more chances we are to convince the parents to do it. And especially if we start between 9 and 10, they don't really think of their children as sexual beings. They think of their children as sexual being when now they're like 14 and 15, and they just don't want to think about it. So they're more hesitant to actually vaccinate at that time. I've had really good success at 9 and 10. Most of my patients 9 and 10 will say yes. Very few of them will be at 11 or 12 or 13. What we need to know is HPV is ubiquitous. HPV causes 6 types of cancers. HPV vaccine is effective. HPV vaccine is safe. There's not enough kids are being protected. We need to vaccinate more. We need to vaccinate 100% of our kids, and 100% of our kids have to be fully vaccinated, because it's not enough to just have one dose. And how we can increase the number of our patients to be protected on time, and that's the whole point of this whole echo, is to get our numbers to go up. The best predictor of vaccination is how we as providers address it and present the information. And I think we're going to have some exercises about how doing that. Our parents place, this is a study that was done in Texas, our parents place vaccine importance of HPV as high as all the other ones. And our clinician estimate of the importance of HPV is very high. But when we say, how do we as clinicians value our parents' importance of HPV vaccine, they are usually kind of low. We think our parents don't really want the HPV. So that's why we are hesitant to present the information. And here is where we're presenting you with the idea of that we need to do better, and our parents do want the vaccine if presented correctly. Now, make an effective recommendation, HPV vaccine initiation rates. So if we don't recommend it, 23% of them are going to take it. But if we highly recommend it, then 73%, and I would say more in my case, will take the recommendation and start their series. So in 2 sentences, Molly needs 3 vaccines today. It protects against meningitis, HPV, and whooping cough. She will get those at the end of the visit. So we do imply consent, and we don't ask them necessarily, it's like, would you like to get this separate vaccine? Because it's not separate vaccine, it's still recommended, and we are the ones that make the recommendation, and we'll talk more about that. But we tell them you are recommended to get your HPV vaccine today. And there's a lot of barriers that we need to overcome, but I think we can figure this out, and we're going to talk a lot about it during the exercises. Our data and aim statement, where are we starting? We are in a good place, but we can be better. But our goal is to get everyone vaccinated. Action plan, how are we going to reach that? That's what we're doing right now. And I'm going to kind of jump over this, quality improvements. So these are all the things that we're going to be dealing with this series. You know, EBM, how to get parents to say yes. EBM, how to present the idea. There are changes that we can do, small changes, and those changes we track with this PDSA cycle of improvement. So we're gonna dig deep into these. I'm not gonna spend too much time into this, but we're gonna dig deep into these of how we're gonna get our parents to say yes. Some key resources that are gonna be presented and allowed, and you're gonna get all this information, all these toolkits of how to get people to the yes. how to get more people vaccinated, how to get patients vaccinated. So CDC, so these are all going to be available for you guys later. And I'm pretty sure I'm super late on time, but we're also going to allow, so Tralisha is going to tell us what the date, time, location, and topic of our next meeting is going to be, but we need to make concrete effort in keeping participating in these presentations, okay? Thank you, that's all. I know it went really fast, but in reference of time, and hopefully I'm still good on time, I'm gonna allow any questions for the public, and then either Dr. Turk or Tralisa or the staff is going to help me answer them.
Yes, thank you so much, Dr. Oquendo. Great presentation, great job. And we want to take a moment now to open up the floor for anyone who has questions, would like to share, or like to ask Dr. Oquendo anything in response to our presentation today. Feel free to come off of mute or use the chat box, but we would love for you to come off of mute.
And I'm gonna take a look at the I saw the chat going like boom, 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 and I couldn't even see it while I was doing the presentation. So thank you for everyone who's making comments and suggestions in the chat box.
Do we have any questions for Dr. Oquendo? Did a great job, Dr. Oquendo.
Well, if there's no questions because the message was clear.
It was clear and concise and to the point.
There might be opportunity for questions after we have our little clinical vignette.
Yes, so what we'll do now, again, thank you, Dr. Oquendo, great job. Thank you for sharing with us today. We're gonna go ahead and-
Thank you for allowing me to present.
Awesome. We're gonna go ahead and move on to we have a role play scheduled for today. I'm sorry, I think, if I could get everyone to please mute themselves after I hear an echo. Okay, thank you. So what we're gonna do today, we're gonna have a role play that's gonna be done by Dr. Jason Turk and Anna Hassan. One part of the echo as we move forward is the case presentation. And what the case presentation consists of is basically a storytelling, an opportunity to tell a story, to tell us what your experiences are like when advocating for the vaccine in your clinics, when talking to parents, hesitant parents about the vaccine in your clinics, or even just what the process is like surrounding vaccines in your clinic. So what we're gonna do to provide an example of what that could look like, what your experiences could look like, we're gonna have Dr. Turk and Anna do a quick role play for us just to show what that interaction might be like between a provider and a parent. And so I'm going to pass it over to Dr. Turk and Anna.
Thank you, Tralisa. So hi, it's good to see you again. How's Ryan doing these days?
Pretty good. You know, he's been at home a lot, can't be with his friends, so a lot of energy. I'm almost welcoming this visit so that you can give him some attention so I don't have to.
Well, I'll do my best.
Cool.
So how old is Ryan now?
He just turned 11.
Excellent. Well, it sounds like he's been pretty busy through the year, and we're getting close to the summertime, and it's good to see you. I'm glad that we're coming out of the COVID lockdown, and I hope we're all looking forward to being able to do more things. Did you have any concerns that you wanted to talk about today?
No, you know, I know we're just here for the well visit. We had to cancel last year, and so I'm assuming we're overdue for something. You know, you had mentioned a few vaccines that he was overdue for, so I'm just hoping we can get those done.
Absolutely. Well, it is time for Ryan to get some immunizations. He's 11 years old, and the immunizations that he needs to get today are vaccinations to protect him against whooping cough, which is also known as pertussis, a vaccination that prevents against HPV-associated cancers, and a vaccine that protects against meningitis. And we'll be able to give those to him today and protect him from those conditions going forward.
Okay, yeah, I think I've heard most of those. Are they all required for school?
So we give vaccinations that are recommended from the American Academy of Pediatrics and the CDC. There are a couple of vaccinations that he's due for today that are required for school entry because they're relevant for protecting against infection when you're actually in school. but that doesn't mean that the other one that's not recommended or required for school is any less important. It's actually very important, and that's the one that protects against cancers that can come from infection with HPV or human papillomavirus.
And I know he's here, but I'm just curious. I've heard some stuff about that one. Are there any changes in behavior or any worry with that happening right now since he's so young?
Yeah, well, tell me some of the things that you've heard of that are causing you to be asking some questions about that. Do you have any concerns specifically?
I had a friend who talked about their daughter being offered that vaccine, and they said that it was only for girls and that they were apprehensive to do it because they were worried that it might give them kind of carte blanche to try something that I think they're a little too young for.
Sure. Well, it's certainly, as parents, we don't look at our 9, 10, 11, 12-year-old daughters and sons as future sexually active human beings. It's not something we're really thinking about right now, but in fact, if you think about this particular vaccination, it protects against an infection that 80% of our kids are going to get at some point in their lives, and usually those infections occur in the teenage and 20-year-old age range. And so this is the right time to protect against this infection that can lead to cancer later on. And then specifically to your point about whether this is a vaccination that potentially could increase the rate of kids having sex or becoming more sexually active earlier on, we actually have done some studies on that. And in fact, kids who get vaccinated against HPV have sexual debut or start having sex at a later age than those peers who do not get vaccinated. And so it's actually the opposite of what you might be concerned about. In fact, if you have an infection that's going to happen 80% of the time, the way you get infected is probably less important than protecting yourself from the infection itself.
All right, I'm comfortable with what you said, and it is. I will have to let my friend know that boys are eligible because I know they have a son too. So I'm going to continue to talk to my friend about that. I appreciate you walking me through it. I think if you believe this is the right thing for Ryan, let's go ahead and move forward and get him vaccinated today.
I think you're making the right choice, and you asked about girls being the only ones vaccinated initially. Well, that's just because we initially had approval for girls based upon the data. As time has gone on, we've realized how important this vaccination is at protecting against cancers in boys, because we're seeing an epidemic in head and neck cancers in men who got infected when they were kids. And so I'm really glad you're making this decision for Ryan.
Thanks for your time.
Wonderful job. Thank you so much. Thank you. Thank you, Dr. Turk and Anna, for a great role play and a great example of what that experience may be like, or engagement might be like between a provider and a parent who has concerns and some hesitancy surrounding the HPV vaccine. So thank you so much. I would like to take a moment and maybe gauge from some of our participants who actually advocate for this vaccine on a regular basis, are putting shots in arms, maybe can share some of your experiences or what those conversations might be like with parents. So I want to open up the floor to some feedback from any of our nurses that are here on the call, any providers on the call that would like to share what their experiences are like. Have been
it might be
like
helpful for our participants to just kind of volunteer some of the things that they've seen and heard in the context of providing the HPV vaccination. And while people are marshaling up their stories to tell, I just would like to endorse something that Dr. Oquendo said, which is how good it is to provide this vaccination at 9 and 10 years of age. It really is an almost different sort of interaction, and the hesitancy that we see in older kids, 11, 12, 13-year-olds, just doesn't seem to be there as much at all for 9 and 10-year-olds. And so it's an excellent time to provide the vaccination, and it's also an opportunity to get the vaccination done at a time when we're not giving other vaccinations. So,
Thank you, Dr. Turk. Okay. Anyone like to come off of mute and share?
I want to say I think that role play was spot on. It happens all the time. I usually use kind of personal examples And I put myself in the position of the parent, in the role of the parent, to be able to convince them. Is like, look, and I tell them, it's like, there's a lot of vaccines out there, and you can make arguments pro and con for probably all of the vaccine. The thing is that if I had to choose a vaccine for my daughters, which right now they can't get it, but hopefully, but when they grow up, I'm pretty sure that this is one of the few vaccines that without a hesitation or a doubt, I would give them. And once you put yourself in the same kind of, you're in the same level, you're not being paternalistic onto this is, you should give this, and they don't understand why, but you put yourself as like, this is what I would do for my family. Then now you're kind of putting yourself on the same level, and they take that information differently, because a lot of times they'll ask us like, what would you do with yours? Like, would you vaccinate your child? And I can answer without a shred of doubt. It's like, yes, absolutely I would. And I think that that is also a very helpful tool when convincing parents.
And if you have gray hair like me, you can say, not this is what I would do, but this is what I actually did. Because my kids are now out of the house.
Yeah, but exactly. But you put yourself as, look, I've been in this position, and this is the decision that I've taken.
I just, can you hear me okay?
Just a little bit of echo. We need everybody else mute.
Yes.
Okay. I really loved, even though Anna, the wonderful mother that she was, agreed in the end, that Dr. Turk, you even took the time to even just add on to the end of speaking on behalf of her comments about girls versus boys, and really highlighting the reason why it's so important, you know, for boys, because there is that big misconception. And I also liked how you touched on the ages, the early age group, because I've had conversations with some other larger health systems that they're like, "Ooh, no, we are not going to, you know, start recommending at 9 years old. Like, you know, we don't even want to get into that." And you know, I said, we have some doctors that were also hesitant. And if you are interested in speaking, you know, to those doctors to learn about their experience, I didn't say your name, Dr. Turk, but you were in the back of my mind because you had a really great experience with that. And I think it is something that people are scared to touch or get into, but actually sometimes it helps kind of alleviate getting into that conversation of sexually transmission and stuff like that. And so thank you you really brought everything full circle of what, you know, what can be discussed with a parent.
You know, I think it's really, really key to remember, it's not just what you say, it's how you say it. And if you walk into an encounter with an expectation that you're going to meet resistance and it's going to be a hard sell, and then that's going to come through in how you are offering the vaccination. And I do my very best when I'm talking to families to have an optimistic outlook and to be positive and in endorsing it, not just with what I'm saying, but how I'm saying it. And I, you know, I think it works well. And feel free to drop my name with the people you're talking to. I'm more than happy to talk to anybody. All right. I would say one other thing, that for all the folks that are on the line who are bashful about talking, I'm going to stop talking in just a moment so they can talk. But I want everyone to remember that every time you see an adolescent and you have an opportunity to provide the vaccination, that is an opportunity for you to protect them against cancer. And you never know if you're ever going to see that kid again. My worst nightmare, and I've said this to some of my vaccine hesitant families, my worst nightmare is that a patient of mine gets to be 30 or 40 years of age and they come down with a cancer that we fail to prevent right now. And so that's how we really need to make it a very important point right now.
Thank you, Dr. Turk and Rachel, for sharing. I do think it's really important that we take advantage of the opportunities that we have now to advocate for this vaccine and to get those shots in arms. What I want to do, I'm trying to leave the door open, but I'm going to call out a couple of names and see if I can draw some comments out. If you don't have any, just feel free to say pass. But I would like to hear hear some voices from some of our participants today. So let me see. Mary A, are you with us? Hi, I can't hear you. I think you're muted. I cannot. I thought we got somewhere, but oh no. We cannot hear you. I can read your lips, but I cannot actually hear you. Trying to see if there's a way for me to assist with.
I suspect it probably is her mic on her end. She's unmuted herself there, but she's going to put in some comments.
Okay.
I'm really great at double muting myself. So sometimes you have to do it on the computer and like your keyboard. But we appreciate you coming on camera. It's always great to see you folks' faces. And
Absolutely.
so maybe while she's typing away, we can.
So Kim Watstrel, I hope I'm saying that correct. I'm glad that you are making the comment about the presumptive approach, and really that it is very important to go in with an expectation that you are going to get a yes, and to present the vaccination for HPV in the same way that you present other vaccinations. This is their age, and this is the time to do this, and we'll get those done at the end of the visit. If you and it's not just important how you say it, it's also important how everybody else in the enterprise that you're talking to, that we're talking about, says it. If somebody asks the question, what vaccinations is your child due for, and the response is, well, your child needs to get the required Tdap and meningitis vaccinations, and we also recommend the HPV vaccination. There's nothing negative about what you said, but you treated the HPV vaccination differently. And so the response needs to be, your child needs to get the Tdap, the HPV, and the meningitis vaccinations. And that's it.
Thank you, Mary. I see Mary made a statement about wishing pediatricians would jump on board. I believe Mary works in Beaumont. Mary is a nurse in Beaumont. And so I hate that we cannot hear to see maybe what some of those experiences are with the pediatricians in your area. I do believe, let's see, Christina Hopkins also works in the Beaumont area, or Irene Barbosa. Are you guys still with us? Are you, Christina? I can see you here. Are you able to unmute and maybe share some experiences with providers?
Well, Mary's got a headset on. Maybe that works now. Can we hear you, Mary?
She's working her butt off over there trying to get off of mute. It is making me so happy. She's like, I got stuff to share.
No, still can't hear you, Mary.
Unfortunately, we still can't hear you, Mary. Virgil,
She's writing in the comments, so I know she wants to participate.
Absolutely. Oh, your Merck rep is awesome as well. Okay, awesome. Thank you so much for sharing. I want to give a moment for anyone else who would like to come off of mute and maybe share some experiences. Let's see, diagnostics iPhone. Your camera's on, so I'm gonna pull you. I'm gonna see if I can pull you.
Is that me?
Yes, that's you.
Okay. Okay. I work with early detection at Moncrief, and we see patients for breast and cervical cancer. So I do mention it to my patients when I do their PAP, that be sure and, get their children vaccinated for the HPV.
Excellent.
And they do take it with them and say, yes, our family doctor mentioned it as well. So I do encourage them to get their children, vaccinated.
Thank you.
You're welcome. Thank you.
So Mary had mentioned, I just wish the pediatricians would jump on board. I think that's maybe an invitation for me to say that it's not the pediatrician who necessarily has the role of being a champion. And sometimes it can be a passionate clinical staff person who can be the leader in raising consciousness and awareness and leading an improvement in providing HPV vaccination. So if you have a fire in your belly and you're working in a setting in which the physicians are not necessarily as passionate about it, then use your passion and point people in the right direction and start advocating for it, because we're all in this together, and we're part of a team in trying to protect people against cancer. And you may be able, as a leader in that setting, to lead pediatricians who have been hesitant for whatever reason to do a better job.
Yeah, and I kind of want to jump on what Dr. Turk just said, as well as this echo. We called it, a medical echo and not a provider echo, not a nurse echo, because really, like he said, it takes a team. Everyone from the person registering the patients coming in, and that, are giving them information on their next appointment or the current appointment they're going, the medical assistants. And so really, when we designed this echo, we want you to feel empowered to be able to pull in your team and members of your clinic faculty. And so, next session, if you go back and you say to some of your colleagues, like, hey, this clinic can really help all of us. Like he said, like, you can be that champion. And this is really a starting point that we wanted to create a platform to start, showing that you can be a champion in your clinic. So Dr. Turk, thank you so much for touching on that.
Thank you, Rachel. So we have made it to we have about 5 minutes left in today's call. What I want to do is, again, thank you all for joining. Thank you, Dr. Oquendo, for a great presentation. Thank you, Dr. Turk, Rachel, Anna, for joining and for giving such great insight. Thank you, Mary, for sharing with us. And I'm sorry, I did not get your name. Whoever it was diagnosed.
Connie. Connie Vega.
Thank you, Connie, for sharing with us as well, and for advocating for the vaccine. Using your opportunity to advocate for the vaccine. I want to quickly just drop the post-session survey into the chat box. So I want to make sure that you guys have access to that and you're able to complete the survey. And then I want to provide a quick reminder, as Rachel just did, we do have another session. Our next session is going to be held on June 10th. Again, that's going to be June 10th from 12:30 to 1:30. And our session topic is going to be presumptive communication. That session is going to be led by our very own Dr. Jason Turk. And so we're looking forward to it, to learning more about how to effectively advocate for the vaccine when talking to patients. Dr. Oquendo touched on that for us some today, and we're grateful for that. And we're just going to take what he started and run with it. And we look forward to continuing to grow and learn more. I'm going to share a case presentation document with you all. And I want you to take this document and use it to share your experiences. And so on our next session, we will devote more time to hearing from participants. So do be prepared to please come off of mute, to be on camera, show your face, and share your stories with us.
There'll be no wallflowers allowed in the next presentation.
Yeah. Right. Thank you, Dr. Turk. So we want to hear from you. The ECHO is a method for us to all learn from one another. And in order for us to do that, we have to share. And so I look forward to hearing your stories, your experiences, how you're advocating in your different clinics and your different areas, where your populations are like. And so I will send that to you guys following this call. And you will also receive your certificates. Again, those will come directly from Medical Learning Group. So if there are no questions, are there any additional questions for our faculty, for myself, any additional questions from anyone? All right, if not, thank you guys for joining. We look forward to seeing you again. Again, that's going to be June the 10th at 12:30 CST, using this same exact platform. We'll be back on Zoom with hopefully more cameras and more voices. Thank you guys, and enjoy your next 2 weeks.
Goodbye, everyone. Have a great Memorial weekend.
Yeah.
Bye, thank you.
And bye, Mary. Reach out if you need help.